Hi there, my name is Max Hardwick-Morris, and thank you for taking the time to listen to a presentation of our work about impingement in patients undergoing total hip arthroplasty surgery. Dislocation is a major driver of vision after total hip arthroplasty surgery, occurring in up to 5% of cases. It is driven by bony or prosthetic impingement and has been linked to adverse spinopelvic kinematics. To assess the risk of dislocation, various preoperative workups have been proposed that utilize functional radiography. The benefit of these are that they are relatively simple and expose the patient to low levels of radiation. However, they have limitations regarding the knowledge of bony anatomy, such as femoral aneversion, which can change a patient's instability risk profile. If we add a CT scan, we can do 3D templating and simulate functional maneuvers that detect bony and prosthetic impingement. A number of these exist in the literature or on the market, but each come with various limitations regarding the consideration of functional positioning and processing speed. So what have we done? We've developed a range of motion simulation that considers the functional pelvic and femoral position and solves instantaneously for any implant geometries. Then, the aim of this study was to use this simulation to investigate the importance of considering functional bony alignment in preoperative planning for total hip arthroplasty surgery. This was a retrospective simulation study of over 400 patients undergoing total hip arthroplasty surgery. The inclusion criteria was for patients to have received a long limb CT scan and preoperative functional radiography, including a lateral standing, lateral relaxed seated, and lateral knee X-ray. Range of motion was simulated using our proprietary software that instantaneously calculates bone on bone, component on component, and component on bone impingement. And implant type and positions were standardized for all patients. We simulated patients doing 2 dislocation-prone movements, standing external rotation or a pivot movement, and seated flexion or a rise from chair movement. Each patient was simulated doing these movements using 3 different bony alignments. The first was neutral femur and neutral pelvis. The second was neutral femur and functional pelvis. And the third was functional femur and functional pelvis. Neutral positioning means that the femur or pelvis is positioned with 0 degrees of rotation. And functional positioning means that the femur or pelvis was positioned with the degree of rotation that was measured in that position using the functional radiography. The targets for a simulation pass or fail were taken from the literature, and we use 45 degrees for standing external rotation and 120 degrees for seated flexion. For the sake of brevity, I will only discuss the standing external rotation results in this presentation. Looking at these results, we have a bar chart that shows how many patients failed the simulation, i.e. did not achieve 45 degrees range of motion in each of the different combinations of bony alignments. And we found no difference between the number of patients who failed the simulation. However, when we dive deeper into the results, distinct differences appear between the cohorts as to which patients fail in each bony alignment. For example, many patients have standing femoral and/or pelvic rotation that escalates them to a simulation fail, what we might call a false negative, when we use functional pelvic and functional femoral positioning as the gold standard. Additionally, many patients have a standing femoral and/or pelvic rotation that de-escalates them from simulation fails to simulation passes, what we might call a false positive. We can also visualize this using an alluvial plot, where each black column reflects a different bony alignment and is split into pass and fail. The red corresponds to patients who fail the functional pelvis and functional femur simulation, which we consider the gold standard, whereas the blue corresponds to patients who pass the functional pelvis and functional femur simulation. This plot allows us to visualize how patients transition into and out of simulation fails based on which bony alignment is simulated. Specifically, we can highlight the false positive patients. These patients were the ones who failed the simulation when a neutral alignment is considered, but passed when their functional alignment is considered. We can also highlight the false negative patients, which were the patients who passed the simulation when their neutral alignment is considered, but failed when their functional alignment is considered. This demonstrates how significant numbers of patients transition into and out of at-risk zones in functional positions based on pelvic and femoral rotation. So, range of motion simulations present an opportunity for more sophisticated modeling of instability and dislocation risk for patients undergoing total hip arthroplasty. Our range of motion model solves instantaneously for any implant geometry and addresses functional pelvic and femoral positioning, whereas previous range of motion simulations do not. Not considering the functional positioning of the pelvis and femur may lead to false positive and false negative findings, which could have consequences. For example, increasing cup anteversion to prevent supposed anterior impingement could lead to edge loading, and decreasing cup anteversion to prevent supposed posterior impingement could result in cup uncoverage that irritates the iliopsoas and causes iliopsoas tendinitis. Thanks very much for listening.